Hello, I'm Professor Yang Seung-min. When it comes to implant surgery, incisions and sutures are the beginning and end of the procedure, especially the augmentation surgery like a GBR. Incisions are very important to determine the outcome. So in this lecture, we are going to talk about the incision design for augmentation surgery. Today, I'm going to talk about these. For augmentation surgery, there are types of incisions. First, the vertical incision. The second is periosteal releasing incision. Two types of flaps can be created using a double flap procedure, which is superficial layer split thickness flap. And summary for incisions for augmentation procedures. Let's start by looking at a clinical case. In the upper anterior, the patient wore a bridge for a long time. Something went wrong, and the patient did not decide yet whether implant or prosthesis in a form of bridge is to be used. The contour and the volume of anterior region is really poor, so augmentation surgery is to be done. There's a vertical deficiency, but horizontally there's a lot of resorptions. Horizontal augmentation is to be done with a block bone type allograft, which is covered by xenograft material. So the horizontal augmentation surgery is done. Then barrier membrane is used. Building a volume was not a problem. However, the problem lied in suturing. As you can see, the volume is quite large, and suturing would determine the success or failure of the surgery. So very carefully suturing is done. If you look at the volume increase, it is quite large, and it's not resorbed that much. If you look at the form of temporary prosthesis, the site is increased quite a lot horizontally. So stable and successful augmentation surgery like GBR is done. The suture should not be broken, so making an incision makes the difference in that regard. Incisions for augmentation surgery. There are three types of incisions: vertical incision, periosteal releasing incision, and superficial layer split thickness flap, which is double flap. First, vertical incision. Vertical incision is different from sulcular incision, which is generally used. The surgical field can be limited with the vertical incision, which is an advantage. The most challenging part when it comes to vertical incision is suturing, and it is difficult to adjust margin of a flap that is dictated by incisions. Using vertical incisions, we can delineate the surgical field from other areas, and the visibility can be secured. So vertical incisions are required for augmentation procedures. Simply put, with or without vertical incisions, if you look at the field of surgery, it can be narrow or wide. In the maxillary anterior region, it is important to delineate the surgical field for later steps. So using vertical incisions, we can limit the surgical field from other areas. The advantages of vertical incisions: it can limit a surgical field. So the surgical field doesn't have to be wide, and it makes it easy to elevate a flap. The most important thing when it comes to surgery is to secure visibility. So access to surgical field in terms of visibility is excellent. And when we need to replace or adjust flap margin, this is helpful. So using vertical incisions can help augmentation procedures in maxillary anterior region. If you look at vertical incisions made here, so overall you can see the surgical field is clearly visible, and you can do the expanded augmentation procedure. Vertical incisions can be located rather away from the surgical site, so scar tissues can be where it is not easily noticeable. So there can be disadvantages as well. One of them is papilla height can be lost. The most influential factor for that is the height of bone in the interdental papilla area, which will be discussed later. The outcome of treatment is pretty good. When we make vertical incisions here, where do we make them? It's not in the interproximal area, and it's not in the mid-labial or buccal area. It's on the line angle in the interproximal area. So we need to understand where the incisions should be made. Apical coronal or coronal apical directions are allowed. The most important principle is that base should be wider than the apex to secure blood supply. So the base should be wider than the apex. Clinically, if we have to make vertical incisions here, where are you going to locate that? Horizontal incision should be made first, and vertical incision design can vary from dentist to dentist. First, in the distal area of the most posterior tooth. Second, in the mesial area of the most posterior tooth. Third, in the mesial of the most posterior tooth, not in a straight line, but in a trapezoid form, involving the interproximal bone slightly. That's how it can be made. Next, interproximal area, all of that can be included up to the tooth right in front of the most posterior tooth. Lastly, it is similar design to the fourth one. The interproximal area is not connected, but it goes horizontally. In the middle, it is more simplified. If you look at here, the direction of the vertical incision, the base is wider than the apex. In the mandible, blood supply doesn't go straight up, it goes up obliquely, so it can be made in an oblique way. So the most posterior tooth does not need to be involved. So it goes with the blood supply like this. Occlusal view shows the base is narrower than the apex, but actually the direction of blood supply, it runs obliquely, so we cannot really say the base is narrower than the apex. The principle is utilized in the curvilinear beveled incision, which provides cutback incision to augment vertically. Between number 1 and 2 in the figure, there's the cutback. That is, the base becomes narrower than the direction that we want. So incision is made like that. If you calculate it vertically in the right figure, if you extend A, B, and C, it can be much longer than actual length. So by giving a cutback incision, the length of a flap can be lengthened. especially this area with the curvilinear beveled incision, the epithelialization is very important. So there are differences in how the incisions can be made. Second, we'll talk about periosteal releasing incision. The advantage of that is overall the tension can be reduced for the flap. What is very important thing is that the flap should be raised sufficiently over the mucogingival junction. By cutting periosteum, the flap can be extended to the direction that we want, especially for augmentation surgery. This is the incision which is very important and you need to know how much can that be extended. According to this study, one vertical incision is made and on the other side another vertical incision, and in the middle periosteal releasing incision. According to this paper, the amount of flap extension at baseline without vertical incision is usually 8 millimeters. After one vertical incision is made, it increases about 13% to be 9.3 millimeters. With the two vertical incisions, it increases by 24%, so 10.2 millimeters. If you add a periosteal releasing incision, 71% extension is achieved to be 13.8 millimeters. So with the periosteal releasing incision, can extend the flap up to 70%, which is a very good option to increase the volume during surgery and to achieve a primary closure. Females showed more extension than males, and mandible showed more extension than maxilla. The periosteal releasing incision is to cut periosteum inside the flap below mucogingival junction. As you can see in the figures on the right as well, when we cut it, rather than the figure on the right, some other method can be more beneficial. Here, when you do the periosteal releasing incision, how can it be extended? If you look at the photos, it can be easily done. At a glance, you can see a lot of bleeding. That's the indication that it is cut. So you can check whether it is cut or not by looking at bleeding. What is important here is, as I said before, inside the flap, how periosteal incisions can be made, like this or everything in one line, like the one on the right that is recommended for consistent tension reduction throughout the flap. Of course, you can use the incision pattern in the left and there's no problem in closing it, but caution, where the incisions are not made, the tension on the flap may cause opening of the suture. The biggest disadvantage of periosteal releasing incision is post-op swelling. As I said before, it causes bleeding. So because of swelling and bleeding, patients can experience discomfort. Hematoma can press down a nerve, resulting in partial paralysis. When swelling or hematoma disappears, things will return to normal. In many cases, various complications can occur. To reduce the complications, periosteum is not cut completely, but it is dissected instead. So this is the modified periosteal releasing incision. It's a type of double flap. GBR is done, and periosteal releasing incision is not done here. The area is dissected instead, as you can see. in the figures, after incision is made inside and it is dissected to extend it. When modification is given, it is extended like this. So this is the initial state, and this much extension can be achieved according to the paper that I discussed. With the periosteal releasing incision, 70% of extension is achieved. If you dissect more, the extension can increase. So we need to do it until primary closure can be achieved. In the mandible, with periosteal releasing incision, the extension can be achieved, but in the mandible, we have to be careful near the mental foramen because a nerve is running in there. So what do we need to do? This is an animal photo showing a nerve running in the foramen. So how can you make an incision near there? So for an augmentation surgery in the mandible, we need to be careful, and that will be discussed in another lecture. Lastly, double flap incision. One flap is formed, but another flap is formed in the flap. So as you can see here in the maxilla, in this case, a little bit different, but depending on where muscle tissues are attached, and the muscle and inside of a flap is dissected, not the muscles, but outside of flap can be extended with this incision. In the illustrations, generally in upper or lower jaws, when vestibule is deep like in the left, muscle is inferior to that, so periosteal releasing incision can be made without a problem. But when vestibule is shallow, the muscles would be in the area that we want to dissect. So the muscles would be cut, which is not really effective compared to cutting the periosteum inside a flap to extend it, and a lot of bleeding can occur. And in many cases, patients complain discomfort. In that case, you can dissect the muscles from the inside of a flap, so it is called a double flap. The layer is split, so superficial layer split thickness flap is made. Like here, the periosteum is left on the left with the periosteum, the bone area inside, and periosteum and muscles remain. The biggest advantage of using this approach is we can get tension-free result. Clinically, severe vertical horizontal bone loss is observed. The root of an adjacent tooth is exposed in this patient. Vertical augmentation is difficult to achieve, so using various approaches and materials, that portion was augmented to get a primary closure, the buccal muscle layer, and the superficial layer is dissected and it's pulled to the front. The flap is formed without exposure and tension-free. Compared to the initial state, a lot of vertical bone augmentation is achieved with the primary closure and no exposure is made. In animal study, you can see the muscles clearly, and that is dissected, and that area is dissected into two layers and it is pulled toward the coronal direction to get primary closure. Summary. In augmentation surgery like GBR, vertical or horizontal bone augmentation, including using block bones, designing incisions is the first step to get good clinical results. It is necessary to understand the several types of incisions which is applied to the augmentation surgery. Those are important clinically. These days, non-incision surgeries are introduced and many people welcome that, which is reducing pain on the part of patients. But it cannot be applied to every patient. Therefore, it is very important to master many different types of incisions, which is very fundamental and basic. I hope you master the basic principles. Thank you for your attention.